I will go through some of these learning objectives. I'm going to start by going over what's sort of more debatable in this field. It's really been growing. In fact, we aren't even able to maybe even identify the classes of these diseases. So I think everyone's really familiar with this circle Venn diagram of the family of spondyloarthropathy. We were taught in med school that the prototypical one is ankylosing spondylitis, and then all the associated ones, as you can see in the other circles. And the reason for this diagram is that they all share some common pathogenesis. So there's sacroiliitis as well as the genetic component of HLA-B27 that kind of puts all of these diseases together. But as we're learning more about treatment and pathogenesis, there's been some change in the nomenclature. There are those in the literature that are looking at maybe a predominant axial involvement and a predominant peripheral involvement as a way to better define these diseases. Now, clinically, as you know, you see these in many different forms, and there's overlap. There are some camps that believe, peripheral in itself, like psoriatic arthritis, is a distinct entity. So I'll go through some of the studies that distinguish these two, but it's always important to know that we're probably, even in the people that study this all the time, are not even clear of maybe how they want to classify these diseases. There is a newer classification that's out now, the ASAS criteria. These are very familiar to you, I'm sure. I don't want to belabor, but basically they're all, these upcoming classifications are all trying to diagnose it earlier. So instead of waiting for some radiographic change, the importance of this classification criteria allows you that even if you don't have imaging, you can go to the other arm, and if you have HLA-B27, you can have one of these two spot features in order to qualify for the disease. If you only have peripheral management, then you follow this algorithm where you have arthritis, and then you need either greater than one spot feature or greater than two spot feature in the other column, and I'll go through some examples. So there's a wide spectrum which has led to all these different classification criteria. So if you look all the way to your, let's see if I can figure out. So if you look all the way here in the smaller box, you see that there's already radiographic as well as spinal changes, but sometimes you don't want to wait till you see those changes to diagnose. So these classification criteria is trying to diagnose earlier and earlier until you get to the first box where you sometimes might not have the radiographic changes, and you might order an MRI to look for some of these changes, and the ASAS criteria is trying to allow us to diagnose even before there are any X-ray changes. Here's an example of an MRI looking at synovitis in the SI joint, not crossing any anatomical barriers and really staying where the SI joint is. And as we are probably ordering more of these to help with certain diagnoses of AS. So what is the role of MRI? I think all of us are probably comfortable ordering these. The problem is sometimes the interpretation for the bone marrow edema can be tricky. There are reasons that patients might have this and not have ankylosing spondylitis. I think it is the test of choice for people in this room who are seeing inflammatory back pain and are wondering if there is any inflammatory changes. But I'm not sure we're ready to be ordering MRIs and interpreting if you have a really low pretest probability, meaning in all young patients with back pain. So you really want to have the understanding that there's some inflammatory back pain component rather than just ordering this as a screening test. So talking about inflammatory back pain, this is probably one of the hardest things that we have to teach our trainees in really trying to understand what this means. There's been many different definitions, as you can see here, of inflammatory back pain. Usually happens in our younger patients. There's improvement with exercise, so that's sort of the big delineating factor versus mechanical back pain. But there's also other features, and sometimes these are difficult when you're in with a patient, and does it wake you up in the second half of the night? Do you get alternating pain from side to side? Do you remember any trauma that's associated with it? Pain at night, I think, is sometimes difficult for patients to really talk to you about. And so whether or not all of these questions will lead you to feel confident that this is inflammatory back pain versus mechanical back pain, which, as you know, is one of the top medical diagnoses and reasons for seeing a medical doctor. So I think these are just an example of all the different ways that people have been trying to define this entity, and how you can practice really getting a good history from a patient to really distinguish this, because this is what's going to help you go on to the rest of the criteria. So we've learned a lot in terms of what we think is going on in ankylosing spondylitis. I always like this cartoon picture because it reminds us of all the different pathways and really making it very different than our rheumatoid arthritis. So you have, if you look here, is the normal vertebrae, and then it shows you 3 different pathways, one involving primarily TNF, or the inflammatory lesions that you see at the corner of the vertebrae. You can then get erosive changes that are and the factors that affect the erosive changes, and then finally you get the bony syndesmophyte formation. So this has led to an update in our ACR for looking at both ankylosing spondylitis and non-radiographic axial spondyloarthropathies. I just wanted to bring your attention, I know this is really tiny, but I'll read it for you, that really patients with active AS, they strongly recommend the use of nonsteroidals, and then also the use of anti-TNF if we're talking about axial involvement. So I think the issue of anti-inflammatories are really interesting. This is something that's gained a lot of attention. Patients can take it over the counter. We can prescribe anti-inflammatories as well, prescription strength, but there's GI and cardiovascular events that are associated with this. So this is an older slide, but just to remind us that in comparison to some of the other diseases that we see, that NSAID-induced GI deaths do occur. And so the question is, how do you manage this disease with chronic NSAIDs and the patient's risks for having a GI or cardiovascular event. So this has led to Vioxx being taken off the market, and now we have both one COX-2 inhibitor left, as well as traditional nonsteroidals that patients can take. So we are at the clinic embarking on a trial that just ended a couple months ago called the Precision trial. It has enrolled over 22,000 patients with RA and OA, trying specifically to understand if there's any differences with the NSAIDs that you prescribe. So we're comparing celecoxib, ibuprofen, and naproxen, and looking at cardiovascular events to see if there might be, if they're equivalent, if one might be better than the other. And really, we are the group of practitioners that are probably prescribing more, long-term chronic NSAIDs than any other group, and whether or not there's any consensus. So hopefully the next time I'm invited to speak, I can give you the conclusions for this. So we are finished enrollment and in a data lockdown stage, and hoping to get some good results. There has been many patients that drop out because they don't stay on these meds for a long time, and so that will be an issue looking at this trial long term, but we have the numbers behind us, so it's a very large trial. So this is challenging in that it remains somewhat of a standard of care in our guidelines, and we prescribe it, but where do we go when perhaps people are still symptomatic based on NSAIDs, but maybe not yet ready for an anti-TNF therapy? So there's still a lot of room and unmet needs in this field. So I'm not going to talk a lot about anti-TNF. I think we're very familiar with its efficacy in ankylosing spondylitis. It does improve function. It's effective. However, not everyone responds. There is an opportunity for us to look at, there is somewhat of a long delay between those that actually have symptoms to the time that they get to a rheumatology office. So I think there's an opportunity there to intervene. And there are lack of probably earlier treatment algorithms that I'll go over in a future slide. So the only slide I have on TNF is really looking at have we learned anything over these past years using this. There's not many other approved drugs for ankylosing spondylitis. So is therapy with TNF blockers more effective in patients with shorter disease activity? Is there advantage if I start them at their very early stage versus an established AS patient? So here's some data looking at BASDI response, which is the typical response that we look at in ankylosing spondylitis. So it does look like Almost up to 80% get achieved results if you treat them within 3 years, while in the established patient, you do get a little bit less at 14% reaching BASDI 50. So there are some data supporting that perhaps earlier treatment is important. And then what predicts those that a good clinical response to TNF. So it looks like the short disease, as I've explained, patients with higher levels of CRP at baseline, as well as younger age, all seem to, in studies, present and as those that might respond better to anti-TNF. So I don't really have any new treatments in ankylosing spondylitis, but I do have to tell you that there's a lot out there under clinical trials. As you know, most recently that secukinumab has been used in the derm world for psoriasis and now approved for psoriatic arthritis and ankylosing spondylitis. And I'll talk a little bit more about that in the PSA talk. And then you see we've had talks on JAK and some newer agents like IL-23 that are in early phase trials for this disease process. So this is looking at secukinumab versus placebo. This is what's in the drug insert for its approval. So as you can see here, the dotted lines is placebo, the solid line is treatment with secukinumab, and at 16 weeks you see the ASAS-20 response up to about 60%. So this is probably more familiar with those that are rheumatologists in this room. We're all just starting to get more familiar with it. You can administer this with or without a loading dose. This is the same dosage for psoriatic arthritis, by the way. At 150 milligrams, you have a loading at 0, 1, 2, 3, and then 4 weeks thereafter. You can also do it without a loading dose. We're probably going to hear from Dr. Fernandez later, but in dermatology, the psoriasis patients are able to actually start at a higher dose at 300 milligrams. The predictors of good response, including X-ray non-progression in these patients, have also been in those that are TNF naive, patients that are male, elevated CRP, and those that have baseline syndesmophytes predict a better response with secukinumab. There are some early studies also in ustekinumab that are showing some meaningful improvement. And I think the biggest area of controversy is probably this area of non-radiographic AS. So more recently, there's been lots of trials trying to focus on non-radiographic. So before there's evidence of radiographic damage, is there indication for the use of any of our drugs? So just having active inflammation is seen by MRI. But however, there's still that new bone formation that I showed you in that cartoon that's probably best prevented by NSAIDs rather than anti-TNF. So I think this area is debatable. I just wanted to bring it up to the audience here and to remind us of the importance of maybe why we're struggling with the nomenclature, is to better understand how to treat in this group, but not quite there yet. So we're going to spend the last 10-15 minutes looking at psoriatic arthritis. This area is very exciting. We've done a lot of work trying to distinguish this disease from rheumatoid arthritis. As you know, in previous lectures, many of our treatments have been borrowed from rheumatoid arthritis, but now we're able to really distinguish. So this is a slide that came from one of our dermatology, rheumatology clinics. I have a combined clinic that I started in Boston and starting to get up in the Cleveland clinic. But this really identifies all the changes that can occur in your patients. You see these demarcated plaques, the nail changes, arthritis mutilans in some of the digits, as well as your typical synovitis, peripheral synovitis as well in the other digits. There are additional other forms of psoriasis other than the plaque psoriasis that I just showed you that can occur with psoriatic arthritis. There are also different subtypes within psoriatic arthritis, which makes it so interesting, and these subtypes can overlap. So you have Mullen Wright, who really was one of the first rheumatologists that collected information on a group of over 100 patients, which started separating us from patients with rheumatoid arthritis, and really were the first researchers that allowed us to understand these differences. So he basically looked at 120 patients and were able to identify certain features features that you see here that collectively fall under psoriatic arthritis. And this has really been a pivotal study to help us look at the difference, both in diagnosis and treatment. So unfortunately, because of all this overlap, it's been difficult to really study this. And so in addition to Mole and Wright, who started this distinction, Helliwell and Taylor then went on to look at sensitivity and specificity analysis to further develop the classification criteria for psoriatic arthritis. So although we don't use this in practice every day, it's just important to know that CASPER criteria has been a well-accepted classification criteria for, I'm sorry, that shouldn't say diagnosis, it should be classification, for psoriatic arthritis. This is what's used to get patients into trials. It's what you need is to gather some points. I just wanted to point out one thing here is that just having a family history does give you 1 point. So even if you don't have a current history of psoriasis. But you do have to first start off with patients with articular disease. And then if you gain greater than or equal to 3 points based on these categories, you'd be classified as psoriatic arthritis. So how do we know how different this really is other than some of the clinical phenotypes? This is an interesting study from 2005 that looked at RA versus non-psoriatic ankylosing versus psoriatic arthritis. I know it's kind of hard to see in the back of the room, but I'll just point to you on this very first slide where the arrows are. The main point of the slide is to show you that there's actually less synovial infiltrates in patients with psoriatic arthritis compared to rheumatoid arthritis. So you see the thickness of RA versus and the thickness of PSA. However, there is greater vascularity, and then there's staining of others. So other markers that you see here that distinguish RA from PSA. So what's interesting about this is that we kind of understand the phenotypic differences in our clinic, but there's also some synovial histology that shows that this is a different disease. I think the big question for us is that we all know that psoriasis occurs in 80% of the time prior to psoriatic arthritis, and it's probably more prevalent than we imagine. But I think there's also this golden opportunity where patients get psoriasis first. So I think developing a relationship with your dermatologist is important, and to have a way to see these patients earlier in your community or whoever you practice with is important. So this was actually a fellows project that I started. I just wanted to show you that in a clinic where we had patients with musculoskeletal pain and patients with psoriasis referred to us, we just decided to look at the first 100 people that came in to say, well, how difficult is this to diagnose? What did we find? So we actually found that these are my referring colleagues in Boston, so these are mostly rheumatologists and dermatologists. So even though they're referring patients that they believe have psoriatic arthritis, only about 40% of that group, from a very well-experienced physicians who are used to dealing with this, when we followed them out a year, actually had psoriatic arthritis. So some of the things were indeterminate, or gout, osteoarthritis. So it's just to show you that it's not maybe as straightforward, even with the advancements of the classification criteria that we have. So one of the things I did in one of my very first research projects was to say, well, how can we help the dermatologist screen for psoriatic arthritis, because you want them to get to your office sooner. So this is called PASE. There are other questionnaires that are out there, and basically it's a patient-reported where you can give it to them, and if they score higher than a 47, they should be referred. So these are some of the studies that we did on the sensitivity and specificity. It's now translated to over 15 different languages and used across the world. So what is the relationship between skin and joint? And despite having all of these studies trying to look at the severity of skin versus the severity of joints, unfortunately we don't really have very good data. It doesn't seem to really correlate as much as you would think. But we do know that if you have severe skin, your comorbidities are increased. But in terms of only looking at those with severe skin, or those are the ones that are going to get severe psoriatic arthritis, not necessarily the case. The next couple slides is really to look at the concept of enthesitis now with the popularity of being able to do much more accurate MRIs and ultrasound, we're able to see some of these differences early on. So this is looking at an MRI of the heel. As you can see here, this really bright area of soft tissue edema. Here's the tendon, and B is for bone. You also have the fibrocartilage in between, and you also have a star looking at bone marrow edema. So really you can see what's going on in these areas of enthesitis, which is very prototypical for patients with psoriatic arthritis. We're also using a lot more ultrasound to help. I was just curious in this room, how many of you guys are using ultrasound as a modality to help? So actually only 20% of the room is raising their hand. So this, as you know, the ACR has been also educating all of us, those who need to be trained in ultrasound as well. So I think this is a really growing area. This is, I thought, an interesting study I just added there. They did ultrasounds in just patients with psoriasis only. And they found that up to 30% had more indolent or occult enthesitis. These are just psoriasis patients. So I think there might be something there. We're just not perhaps doing the right imaging to look at all of these enthesitis. These are just to remind us of all the different enthesial sites. They are a lot of different measures that are out there trying to better measure enthesitis. And this is basically one, it has 6 sites versus 18 versus 13. We haven't really agreed on one, but just thought I'd mention it. So I think the biggest explosion is really our understanding of the immunopathogenesis in this is probably one of the more important slides for this morning. So really the focus has been in this enthesitis area where tendon attaches to bone are these specialized T cells. So these can be activated by IL-23, and these resident T cells are those that can be stimulated and cause some local inflammation and bony changes. So the T cells that sit in this specific area can then activate IL-22, IL-17, which then leads to the clinical phenotype that we see in our office. So the question is, well, how do these resident T cells get stimulated? So they are through a pathway through IL-23, and there is some controversy on how IL-23 can really be activated. So whether we heard earlier today on the gut microbiome and dysbiosis, it could be a genetic unfolding of protein issue, or what many of us also look at is, that's really interesting, is that it starts at these sites of enthesitis where we get a lot of trauma, like just mechanical stress, which then can perhaps induce IL-23. So with this in mind, our treatment paradigms have allowed us to look at other more specific cytokine therapy in psoriatic arthritis. So this is just a diagram to remind us that there's no sort of one way to look. We have to look at the skin and the joints, which kind of adds to the complexity of treating these diseases. So first, looking at the ones that we're most familiar with, TNF inhibitors. So here is a graph looking at all the different TNFs in psoriatic arthritis in the phase 3 trials. So the first bar I'm going to show you is in green, is the ACR 20, 50, and 70 responses that you see in the various TNF. So we have, good response at ACR 20 in the 50 to 60 range, going to about the 20% range with ACR 70. But what I think is really interesting is if you superimpose this with the dermatologists, they really got us beat. So for the skin, we're clearing it much better than we can in the joints, and so that's the reason for this slide. So we are still not able to get to some of the high responses that the dermatologists are able to do at the skin as we can do in the joints. So that's led to looking at other treatments for psoriatic arthritis. We already spent some time on intracellular signaling or small molecules that are being used. We talked a lot about JAK. Those are in some earlier trials in psoriatic arthritis, and currently in other small molecules as well. The one that is approved is a PDE4 inhibitor, apremilast, which is an oral medication used probably more for the mild to moderate psoriasis and psoriatic cohort, and as you can see here, it comes in intracellularly, it inhibits PDE4, which then increases cyclic A and P, which then allows to mediate the pro- and anti-inflammatory mediators. Has a pretty good side effect profile in terms of safety. It doesn't really have a lot of sort of regulatory surveillance that you need per its drug insert. And then comes to the big show in rheumatoid, in psoriatic arthritis, which are the IL-17 inhibitors. So this is just a cartoon simplifying our treatment in psoriasis and ankylosing spondylitis is really looking at the Th17 pathway. So no longer looking at just whether this is a Th1 or Th2 mediated disease, and one of the ones that has been recently approved is secukinumab, and coming shortly is probably ixekizumab, and this is an IL-17A. There are many different types of IL-17A through F. This particular secukinumab has been approved as an IL-17 blockade. There's also been others in the IL-17 family. So brodalumab is actually a IL-17 receptor blockade, and as many of you have heard, has stopped its clinical trials due to an increase in sort of mental health issues. So there's been unfortunately some cases of suicide in the treatment group compared to the placebo group that's led to they're not pursuing brodalumab right now in psoriatic arthritis. But secukinumab is around, and other IL-17s are also in later phase trials. So I also wanted to, I know this is a busy slide, but the GRAPPA, which is a international research group on psoriatic arthritis, just published their GRAPPA treatment guidelines, as you can see here. And I think the point I want to make with this busy slide is that treatment is now really focused on domains. So these rectangles are meant to help the clinician look at whatever domain is affecting the patient most, and then the algorithms get shown or get followed by whichever domain is dominant. Now we do know that patients have, overlap, but once again you can see on the very first box that nonsteroidals once again are your first line in terms of treatment for these patients, and if they don't respond, then you go on to the algorithm of using definitely TNF and sort of the axial disease, and then looking at the peripheral disease, other biologic DMARDs as well. And then of course skin and nails can get affected, and for the first time we have much better treatment than we had in the past for those. The other concept I wanted to make is of tight control in psoriatic arthritis. So just like in rheumatoid arthritis, looking at the concept of treat to target, we have TICOPA, which is a study looking at a tight control versus a usual care, and we see that in tight control we can reach to minimal disease activity better than we can with regular. So it looks like treatment escalation, or the treat to target concept, also works in psoriatic arthritis. So we do still have some major gaps in that 45% of psoriatic arthritis patients do not respond to DMARD, so there's still an area where we're looking for other drugs. There's an absence of biomarkers to predict which patient might respond to treatment, and obviously since we don't have a consensus on skin and joints and comorbidities, I think that that's going to probably be the next phase where we can actually affect comorbidities as well in the treatment of a patient. These are some of the other emerging therapies. I talked about the ones that are approved, but just to let you know that there's many others that are close behind in late phase trials also, and then dual inhibitors as well. So I want to get you guys to your break, so I think I'm going to skip some of the comorbidity areas. Cardiovascular is an area of interest of mine. I could tell you a little bit about what we're doing about cardiovascular comorbidities. There are other comorbidities I don't have time to talk about, which is inflammatory bowel disease. We now know that that's much more common in patients with psoriatic arthritis and ankylosing spondylitis. I think with the gut microbiome, you're going to hear a lot about that coming up. But in terms of cardiovascular, I just wanted to let you know that on main campus, because of this increased risk, we've decided to make a pop-up window that shows up anytime that you have an inflammatory arthritis, whether it be RA, PSA, or AS, and then we refer to our cardiologist. And that's one way we're dealing with it. There's many different ways that other people deal with it. I'm not saying that this is the one and only way, but I think it's interesting that we are working closer with other disciplines to help our patients, and I just wanted to bring that point across. And so just to end up, I think that there is some importance in really co-management. So there's been studies looking at patient satisfaction and other things, not so much cost effectiveness, yes, but I think this area is very interesting to how do you co-management with patients? Do you just send a letter? Do you pick up the phone? So luckily I have a hotline to Dr. Fernandez, who you'll hear from later today, who's a dermatologist. But I think developing that rapport to really take care of the patient has really helped me get them to treatment. And now that we have treatments that are available in both disciplines, I'm learning a lot from dermatologists and the treatment of psoriatic arthritis. So this is just my last slide, just to summarize how to care for and I think what I'm trying to do is explain and encourage you guys to pick up the phone, because I think there's a lot that can be learned rather than our digital age of just emailing and sending notes. I think it's been really helpful to just pick up the phone and talk to your cardiologist or your dermatologist in co-managing these patients. So just want to thank the people that are involved in the research and some of the slides that were made today, and to remind you that we're not so far away if anybody wants to visit us on main campus. Thank you.